I'm finishing up my lunch on a Tuesday afternoon. It's about 12:50 p.m. I'm thinking to myself, great, I have 10 more minutes before I need to be back in the stroke consult room, so maybe I can grab some coffee, have a nice warm beverage as we sit around on our patients that we need to see in the afternoon. Then all of a sudden, my phone goes off. It's a stroke code to EMS triage in the ED. I look around at the mess on the table. I have no time to clean it up. I need to get to the ED as soon as possible so that we can see the patient. Because every moment that we're not there, every moment that the patient is not being seen and treated, brain could be dying. As we say in neurology, time is brain. So I leave the mess on the table. I grab my neuro kit with me and rush to the ED. The fastest way to get there is through the outside. It's January and we just had a blizzard, but I know that I need to get to the ED as soon as possible. So with just my vest on, I go out the door, walk to the ED in the freezing cold, and arrive. I see a big group of people huddled around a gurney. There's a patient there. I see pharmacists there. They're always activated. Just in case this patient qualifies for the clot busting medication, they're there on standby. And I see the ED talking to the family member. By the looks of it, this must be the patient's husband. I hear them saying to themselves, we're just waiting for neurology. I'm neurology. I get to the bedside, I ask the ED, what's going on? They tell me that it's a 42-year-old woman with sudden onset weakness on the right side, and she's having trouble speaking. This sounds like a stroke. That's the first thing I think to myself. This sounds like a stroke. Next thing I need to know, when did the symptoms actually start? Because if it's within the clot busting window, the T&K window, then we can give her a medication that might be able to save her from her symptoms. I get a little bit more history. The symptoms started around 10 a.m. Okay, I have a time. But is that the last time she was actually known to be well? Because I need to know the last time she was normal to be able to decide if it's safe to give any medication for this stroke, this possible stroke. They say yes, she was having breakfast with her husband. She was acting normal. All of a sudden, right away around 10 a.m., she started having the weakness on the right side. Her right face started to droop. She was having weakness in her right arm and her right leg. And over time, she was also having difficulty speaking. All right, we know the last known well. That's such an important thing for me to know on a stroke consult team, to know whether or not I need to give the medication. Next, I need to know, does she have any contraindications to this medication? Does she have an intracranial mass? Is she on any blood thinning medications? What is her blood glucose? Because sometimes just having a low sugar level can lead to these symptoms. I go to her and I start doing my exam. Overall, what I'm trying to know right now is, what is her NIH stroke scale? What is the magnitude of her deficits? Based on her exam, she has an NIH stroke scale of 7. She got points because she's not able to talk, she has weakness of her face, and she has weakness of her right arm and her right leg. These are severe symptoms. She's in the window for T&K, the clot buster, but I need to make sure that it's safe to give. So the next thing that we need to do emergently is put her through the scan, the CAT scanner, and see if there's any blood in the brain. Because if there's blood in the brain, then we cannot give the clot busting medication. We put her on the table, we strap her up, she goes through the scan, and I'm in the reading room, right outside the scanner, looking at the images as they come in, looking for any sign of a bright signal, any sign that there might be blood and we can't give her this medication. Luckily for her, there are no signs of a bleed. Her brain, her CAT scan looks normal. That doesn't mean there isn't a stroke, but at least there's no blood in the brain that would prevent her from getting the medication. Next, what we need to do is look at her vessels. Her syndrome looks like maybe there could be a clot in a large vessel, and then she could go for a thrombectomy or a removal of that clot in the vessel. We do the vessel imaging and we see no large vessel occlusion. She's not a candidate for an intervention to take out the clot, but she's still within the window for T&K. She's within the window for us to give her a medication that could help improve her symptoms compared to people who don't get this medication. The thing about this medication, and what I think about a lot as a neurologist, is that it does have some risk. And I have to talk to the patient and her husband about this medication to let them know the risk and the benefits of receiving this medication, what the benefits are and what the risks are. It's a scary medication to give. I've given it before and I've seen people improve. I've seen their symptoms get better. But I've also seen this medication be given and the worst thing possible happens. There is a brain bleed. With this medication, it's a clot buster. It's making it more likely that they bleed. The family agrees to get the TNK and make sure that she doesn't have any other contraindications, whether it's an intracranial malignant process, whether it's any medications that would increase the risk of receiving this medication. And she doesn't have any contraindications to receiving the TNK. I talked to the family and they agreed to receive the TNK. In my mind, I'm happy that she came in time for us to be able to give her the clot busting medication, the TNK. And the pharmacist mixes the medication and hands it to me. I am the one responsible for pushing this medication through her body for it to reach the brain and help with her symptoms. This medication, we push it over 5 seconds. 5 long seconds of me hoping that her symptoms improve and also hoping that she doesn't have a symptomatic brain bleed. I push the TNK, everything's okay right in the immediate moment. Now we just have to wait and watch and observe. We do neural checks. We check on her every 15 minutes to make sure that she's not having any symptomatic side effects from the TNK. In addition to doing the neuro exam, we're also looking at her vital signs every 15 minutes. We're checking on her, making sure she's okay, and she goes to the ICU, the neuro ICU, for further monitoring, close neurologic monitoring. The stroke code is over. She received the TNK, and I still need to go back to join the stroke consult team so that we can round on our patients for the afternoon. The whole time I'm still thinking about my patient that received the TNK. Is she going to be okay? Is she going to have a neural deficit that makes us go to the CAT scan right away and see if she has a brain bleed or not? And the first thing I do when I get back to the hospital the next morning is check her chart. She's doing okay. She's in the neuro ICU. So based on her symptoms of right-sided weakness of her face, her arm, and her leg, and then also the fact that she has difficulty speaking or aphasia, I'm thinking that this stroke is likely in the left frontal area. And what's really interesting about the left frontal area is that we have a region called Broca's area. And for Broca's area, that's actually what helps us speak. And so there's this phenomenon called Broca's aphasia. So when we have patients that have difficulty speaking, we're thinking that it's likely in the left frontal area, especially since she's right-handed. So that means that her dominant speech area is likely on the left side. So even though the CAT scan didn't show a brain bleed or stroke at all, I still need to be able to think to myself, do these symptoms make sense in the setting of a stroke? Could I localize it to a specific vascular territory that would make a stroke more likely? And I was able to localize it likely to the left middle cerebral artery area, or the left MCA, giving her symptoms of right-sided weakness and difficulty speaking.